Welcome everyone to tonight's webinar. This is the fourth in our series on our demystifying dementia webinars. This event is a collaboration between Coordinator and Capital Health Network, who run the ACT Southern New South Wales Health Pathways Programme, Illawarra Shoalhaven Health Pathways Programme, and Dementia Training Australia. My name is Jill O'Donnell, and I'm the ACT and Southern New South Wales Health Pathways Manager, and I'll be introducing our speakers tonight. We'll start with acknowledgement of country. I'd like to acknowledge the traditional custodians of the lands we meet on tonight. I'm currently on Ngunnawal country, and I know we're spread across this wide region. I'd like to pay my respects to elders, past, present, and emerging, and acknowledge and welcome any Aboriginal and Torres Strait Islander people who be here tonight. Before we begin, just a few things, a bit of housekeeping. If you can put your full name in your Zoom profile so that your name can be recorded for CPD reporting, and it just helps to see if there's any Q&A at the end, see who you all are. The session's being recorded and your cameras will be off throughout the session. If there's any questions, put them in the Q&A function and the speakers will address these as we go through. After tonight's session, you'll receive an online evaluation form to complete. Please take the time to fill this in. We're just keen to understand how you find events and what your future learning needs might be, particularly around dementia, but other topics as well. You'll receive a certificate of attendance after you've completed the evaluation, and GPs who are registered for it will get their RSE-GP points as well. So as I said, this is the fourth in this series. Tonight's webinar is focused on changed behaviours in dementia. You can see the outcomes on the slide there, and I'm sure the speakers will be going through this when they start. These webinars are part of the Department of Health and Aged Care funded Dementia Support Pathways project. This project's been running for over 2 years and involved development and evaluation of our dementia health pathways. Health Pathways provides evidence-informed, peer-reviewed and localized information, which is designed for use at point of care for GPs and health professionals. So pathways are written by a team of local GP clinical editors, and we work closely with the hospital system, GPLUs, and subject matter experts to ensure that pathways are accurate and relevant in our region. So there are multiple dementia pathways which have been localized with refer information in our region, so you might be interested in having a look at them afterwards. So on to our speakers. Tonight's speakers are Dr. Rebecca Moore and Dr. Peter Silberg. Dr. Rebecca Moore graduated from the University of Adelaide. She has a varied career, initially as an Aviation Medical Officer in the RAAF, and she's since worked in general practice and urgent care in the UK and in Australia, and is now working as a GP in Newcastle. She's a special interest in aged care, and in 2022, she worked as an advanced trainee in Geriatrics and is currently completing the Masters of Dementia through the University of Tasmania. She's also an educator with Dementia Training Australia. Dr. Peter Silberg is an experienced GP supervisor and medical educator. He joined Dementia Training Australia as a medical educator in 2022, and he's worked in many primary care sectors and currently works as a GP and is the lead clinician at the Rekindling the Spirit Health Service in Lismore, Aboriginal Medical Service, and as a GP at the Lennox Head Medical Centre. I'll hand over to the speakers now. Thanks.
Thanks, Gil. So just give us a sec while we get our screen up. Okay. Hi, Beck.
Hello.
How are you going?
I'm well. How are you going?
Good. I just learned something about you, that you were in the RAAF.
This is true. Yes, I was.
Were you flying planes?
No, I was looking after the people flying planes.
Are you looking after people flying planes? Right, okay, so you can do the aviation medicals.
Yeah, that's right.
That sounds like a cool job. So welcome along, and hi everyone tonight to this webinar on changed behaviours in dementia. So I think we've been kindly introduced, Beck, so probably is there anything else you want to tell anyone about yourself?
No, all good. It's a bit embarrassing, really.
So I'm the same. So I guess just to sort of summarise that both Beck and I, GPs like yourself in the meeting tonight, or maybe you're a nurse or allied health practitioner, we work in community general practice in various roles, ranging from Aboriginal medical services to mainstream general practice and aged care facilities. So we're excited to bring you this talk this evening, and this is part of our sort of what do we call it? Extended skills, is that what we've called it? Or
Yeah, extension workshops. Yeah.
extension workshops. So we assume that you have some background and basic knowledge in dementia diagnosis. If you don't, then perhaps grab a look at maybe one of our pre-recorded webinars from the PHN. So tonight we're going to talk about behavioural change behaviour in people living with dementia. And like everything we do in medicine, it's really important we use a person-centred approach in this topic. And we're going to explore both the non-pharmacological things you can do, which is probably the mainstay really, and also what evidence-based pharmacological care you might like to introduce if needed. So Beck, we always start these talks talking about language when we're teaching about dementia. It's pretty important, isn't it? Because there's still some sort of stigmatised language out there in the community from both our colleagues and also the patients.
Yeah, I think that's right. And I think there's a lot of feedback from people living with dementia that the way that we talk really has quite a significant impact on how they feel. And I just think we need to be mindful. There's some really excellent dementia language guidelines in Dementia Australia on the website. So that would be something to look for. But Pete and I, you'll notice that we use the term a person living with dementia because the dementia doesn't define the person. So not a person with dementia, and definitely not somebody who is dementing. And similarly, tonight our talk is going to be about behaviour. And these days we talk about changed behaviours or expressions of unmet need. And essentially that's what a lot of the behavioural changes are in regards to trying to ascertain what it is that this person is trying to communicate to us. And so trying to use language that, again, it doesn't define them. So we're not talking about the screamer, we're not talking about the wetter or the wanderer, we're talking about a person living with dementia and trying to be quite accurate in describing what the behaviours are. So we're using language which is respectful and empowering and non-stigmatising. That makes sense?
Thanks, Beck. So what do we mean by changed behaviour? So there's quite a few different topics on the screen there. And I guess thinking about this talk, I mean, it's obvious because that's who we're coming from, Dementia Training Australia, but we are talking about changed behaviour in people with dementia. And how does that really sort of change things? Well, by definition, to have dementia, you have to have a progressively declining change in your cognition that's affecting your everyday activities, your function. And particularly at certain stages, it may be that change in cognition really affects your ability to express yourself. And either it could be you can't find the right words, or it maybe you lose your capacity to talk altogether in the very later stages of the illness. Or it could be that your brain just doesn't have the capacity to sort of put the right sentence together to express how you feel. So that's really kind of a major sort of concept of what we're thinking about today, isn't it, Beck?
Absolutely.
Yeah.
And it's important to note too that actually we can get changed behaviours quite early as well. In fact, sometimes it can be one of the first things that you will notice, that somebody has become more withdrawn, or they're experiencing this sense of apathy, or you know, I've certainly got it wrong before and attributed somebody's dementia to an anxiety disorder, where in fact it probably was that sort of prodromal or behaviour change related to the dementia too. But I think mostly what we're talking tonight about, as you say, Pete, is the changes that tend to occur later when it's more difficult for a person to express themselves.
Express themselves too, yes. And you'll also see down the bottom of the screen there that there can also be some more significant types of change behaviour, like hallucinations, which could be a component of the dementia, doesn't as separate to a psychotic disorder. So that's something we'll talk about later on in terms of the mental health symptoms when it comes to change in behaviour. So we've got a bit of a case, Beck. We've got Anna. She's on the screen there, and she's got 82, and she already has a diagnosis of Alzheimer's dementia. And you've known her as a GP for some years now. In fact, as a GP with some upskilling, you felt confident to make the diagnosis yourself some 7 to 8 years ago, and you've been looking after her ever since. And things have been getting harder for the family and for Anna of late, particularly around areas of safety and their ability to be able to cope and care for her appropriately at home. And she was needing more and more care, to the extent where there were challenges with transporting, being able to get to the toilet on time, being able to do some basic things around her everyday care, like dressing and feeding. And it was decided that in a timely manner that she needed to explore going into an aged care facility. So that was planned ahead, and she's just made the move. Actually, no, someone's changed the case for me. In this instance, she's made respite care after a recent hospitalisation. Geez, I'm
She's
rattling
been
on there.
thinking about it already, but yes.
Case, but either case, we'll go with mine. Mine sounds better. So she's gone into aged care facility, and they've just contacted you to ask you to review Anna, as she's, in the nurse's words, has become confused and keeps calling out. So you're the GP on the end of the phone, and you're thinking, what's going on here? So have you got a framework that you use to try and figure this out?
Well, I've got a couple of frameworks. I mean, I imagine this is quite a common sort of occurrence. I don't know how many of our audience look after people in the nursing homes, but certainly this is quite a common scenario. So, I mean, we have this framework, which I think is one of our take-home messages tonight. But also I like that framework, the ABC framework, in the sense that you're trying to work out the antecedent behaviour, you're trying to work out what the trigger was for the behaviour, what the actual behaviour is, and what the consequence of that behaviour or what you've done to remedy it has been. So like in terms of the behaviour itself, I try and use that approach. If we can identify a trigger, a behaviour and a consequence, but also for the purposes of the talk tonight, we want to make sure that you have a bit of a framework in your head as to, in this circumstance, how you approach it. So firstly, we would be looking to see, could this be a delirium? Could it have a biological cause? So certainly if things have suddenly changed and become quite acute, delirium has to be something that we consider. Could it be an environmental trigger? And we'll talk about them later. Could it be an underlying mental health or psychiatric cause? And could it be a combination of all of the above? And could it be that her dementia is progressing?
Yes. Oh, that's really helpful. So we've got the big three sort of groups there, or maybe a combination. And we're going to talk through those one at a time now. So the first one is, could it be a delirium? So a delirium is something that comes on very, very quickly over hours to days, as opposed to a dementia itself, which comes over months to years. And it's a changing in fluctuation in confusion, essentially, and it can lead to all sorts of changes in cognition. You can have like a hyper aroused state, or you can actually become apathetic and withdrawn. So it can be a bit tricky to pick, but it's something you need to have at the top of your diagnostic tree, isn't it, Beck? Because a delirium is a medical emergency, isn't it?
Yeah, a delirium is really an alarm bell that the brain is failing, and we need to try and determine what the underlying cause of the delirium is. Yeah.
Yeah. Why is it such an emergency?
Well, I think it suggests that the brain's not getting what it needs. And so, I mean, there's lots of hypotheses as to what actually causes a delirium. Certainly, there's some talk about glucose levels and that sort of thing. But certainly, we also know that people who have extended delirium have less good outcomes. And I think sorry, Pete, I was going to say the other thing is to note that people who have a dementia are more likely to develop a delirium, and also people who have a delirium are more likely to develop a dementia. So it's always a little red flag if somebody has had a delirium in hospital, to make sure that once that delirium has resolved, that you still monitor their cognition to look for any dementia as well.
Yeah, so it's an emergency. One of the reasons I've always been taught is because, like you say, the longer it goes untreated and reversed, the poorer the outcomes. And the quicker you can reverse it, the more likely the person will return to their baseline level of capacity and function.
That's right.
Their brain function. So there's different reasons why you can have a delirium. The other thing I was going to say there is, you mentioned that people with dementia are more likely to have a delirium, or a greater risk of having a delirium. So just explain to the audience why that is.
Well, again, I think it's a little unclear, but what the philosophy is that people who have a dementia have reduced cognitive reserve. They don't have the same number of neurons and synapses to make their to help with their thinking. And so, if you add a delirium to that, it's unmasked earlier. Does that make sense?
Yeah, that does make sense. So here's three large big areas of things you need to think about for delirium. I'm guessing that the people online have probably seen these sort of things before, and there are some pretty good sort of flow charts you can use and checklists that they have in aged care facilities to make sure you're not missing anything. Probably one that's probably maybe forgotten a bit is the one on the left, particularly for people who've just moved into an aged care facility. And alcohol withdrawal is something that needs to be remembered, isn't it?
Absolutely, yeah.
Yeah. Anticholinergic load, so that's got to do with medications, yeah?
Yeah, and again, the fact that she's just been in hospital is always a bit of a red flag too. But anticholinergic load, there are many common medications that we use that have quite a high anticholinergic burden. And we know that those medications can affect cognition, and it's sort of a cumulative effect. So some medications have greater anticholinergic load. For example, classic ones that we would see a lot in the hospital would be amitriptyline and oxybutynin. But then also other things, it's just a cumulative effect. So things like beta blockers and frusemide and some analgesics, antihistamines. A combination of all of those might again be enough just to tip somebody over their edge. So definitely worth having a look to see what the anticholinergic burden is, and also if any new medications have been started. And certainly in hospital, often pain relief is started and is a very common cause for a delirium.
Yeah. And then this the middle box around the physical causes of a possible delirium, that's a really good list, but it's also not a bad list just for change in behaviour with someone with living with dementia in general, isn't it? And we're probably going to touch on some of these a bit later.
Yeah, definitely. And again, being in hospital, the risks of dehydration, where a person's hydration is just kept a bit out of reach, they're not sleeping well, often quite disorientated, possibly in pain. And certainly then the corollary of all of that is constipation. So yeah, all of those things are probably more likely to occur in a person who's just been in hospital.
Yeah, and then the last group is the organic causes, and they're the sort of things that you need to be looking through your fever and acute neurological signs, plus your investigations like your dipstick urine and potentially blood tests if appropriate, which I'm sure people are pretty onto.
That's right.
So here's a trial that was had some fairly sort of changing outcomes, isn't it? And the way we think about this sort of stuff.
Yeah, I find this really interesting trial because it's so simple, and it involves several thousand patients. And basically, people were put in different wards, and on one ward they were paying special attention to those 6 items on the list, and in the other ward they were just doing their normal sort of treatment. But in the ward in which they did the interventions, and they're really simple things like making sure a person has their glasses, their hearing aids are working and the batteries are fitted, that a physio is coming every day to help them mobilise, that their water's kept in reach and that there's no alarms and that the lights are switched off at night so they sleep better, and some sort of orientating devices like clocks and calendars, etc., and good signage. With those very simple interventions, they were able to reduce the risk of developing a delirium by 40%. And those people who did develop a delirium had a shorter delirium generally as well. And so it's just something, again, to bear in mind for people, particularly in the nursing homes, just to keep those things in the top of your mind. And also, I was saying to Pete earlier, if you've got a person who does have a diagnosis of dementia and they're going in for an elective procedure, say in the hospital, just being aware of those things and making sure that their family members are able to address some of them will reduce their chances of developing a delirium as well.
And they're really pretty basic sort of human rights, really, aren't they? It makes you
I know my grandma.
Quite concerned about what they're doing in hospital on the ward where they weren't doing those 6 things.
It's crazy. Yeah, my grandma, she was put on endone and developed delirium, but actually a lot of it was because she couldn't hear very well and her hearing aids had gone missing. It was something as simple as that, and it really set a difficult spiral there.
Yeah. Well, I think that's a really good take-home message, just to go back to basics. So let's go back to Anna. So she settles with a bit of hydration and just getting used to being in the aged care facility, a bit of reassurance, family members coming in and visiting her, and those kind of things, maybe some environmental triggers that remind her of things that are close to her. So that's good. So there wasn't a major delirium there. It was more probably from the stuff around the HELP trial. But as things keep going for her, she's still a bit agitated at times, and tends to call out then now and then, and can walk into other residents' rooms, which can always be a bit disturbing for everyone, really, family and the other residents, and probably not usually Anna. The amount I have much insight into what she's doing. So let's go back to our framework. So we've talked about delirium and the biological causes of delirium. So we've touched on the environmental triggers through the HELP study. So let's explore that a bit more, Beck.
Sure. So again, sadly, this is quite a common thing, especially in the nursing home environment. Sometimes there is the overstimulation. So there are lots of noises, lights on, alarms, that kind of thing. But often too, I've found that people can feel quite bored and understimulated and without purpose. And I think that can both lead to changes in behaviour and also to low mood as well. So trying to ascertain if there's any specific triggers, this is a really good time. I've had a couple of examples. I had one gentleman, and every time he sat in a certain chair, he would become quite agitated at certain times of the day. And it became evident that the light was just coming in through the window at a funny angle, and the glare was really affecting him. It was a very simple thing, but we moved his chair and it was fine. I had another lady who...
I think just to cut you off there, Beck, I think the interesting thing about that is that he didn't have the capacity or the cognitive capacity to tell you that.
That's right. It was a real guessing game, but that's exactly right. Yes, and just recently, another one of my lovely residents, she would become quite distressed because her door was right near the meal room, and people kept going into her door thinking it was the exit. And so she would become quite agitated because everyone kept coming into her room.
Fair enough.
Yeah, it made sense. And a simple move was actually made a huge difference. So simple things like that. Sometimes it can be to do with the surroundings. I remember another lady who didn't like to go to her toilet, and we worked out that it was, well, I think it was to do with the tiles in the toilet, because she always felt like there was water on the floor, and I think she was having difficulty with her visuospatial reasoning, and again, so sometimes a little bit tricky to work it out, but it's certainly worth having a good go.
Yeah, I think it really goes to the wonderful job that nurses in aged care facilities do, because they're the ones that are with the patients all the time and know them really well, and they're the ones who really work these things out, aren't they? I mean, we just sort of swan in for half an hour, but they're the ones who really know this sort of stuff. That's
right, and you find that some residents will have staff that they seem to connect well with, whether it's just the pace that person takes or their approach. So trying to provide that continuity too is really helpful and important. Yep. And definitely finding activities that can provide a person with purpose, trying to work out what their previous occupation was or what sort of things brought them joy previously, whether it be folding the napkins for the table service or, setting the table, or reading, reading groups and that sort of thing can be really.
Yeah, and I think of course, the other people in this equation are the carers and the family. Probably, generally can have some good input into perhaps what's going on.
Yeah.
And need to be talked to.
Absolutely. And actually, one thing that our colleague Steph was talking about, when she does her advanced care plans, so several years usually before all of this, she makes sure that the person will talk to her about the things that they enjoy, their favourite songs, their favourite music, activities that help calm them and make them feel good. And she says that can be very useful, particularly if when people do go into residential care, often their doctor will change. And sometimes these people don't have family to sort of advocate for them. And so having an advanced care plan, which does state the sorts of things that this person enjoys, can be very beneficial when they do move, so that you can tailor their person-centred sort of interventions. I thought it was a good tip.
Yeah. And then there's things like music therapy and I'm guessing animal therapy is bringing in pets.
That's right. Music therapy is amazing, and they do it in the hospital, on the children's wards, etc. too. So we know that music therapy basically lights up all the brain. It's very good for cognition, but it's also very good for relaxation. It's something that's familiar to people. It's culturally appropriate, and people will often remember the words to songs and that sort of thing because their long-term memory is quite intact. So music therapy can be listening to music. It can be being involved in the making of the music, instruments, all kinds of things. And certainly for some individuals that can be really.
Yeah, and I think the aromatherapy sounds like something that might job here in the northern part of New South Wales, but there is some good evidence around that, isn't there? Probably something using the senses of the smell, I guess.
That's right, and good for relaxation. But again, most of these interventions, most of the trials, there's not great evidence for much because partly I think a lot of the trials are done in groups and a lot of the trials are only done on small numbers of people. And so, again, it's trying to work out that person-centred individual approach because, a whole group might not find it beneficial, but there might be one or two people within that really respond well. So, the other thing about animal therapy is that physicality of it too. And so it does get people moving, and certainly exercise, we know, can be another really good non-pharmacological intervention.
So here's some resources that we've got at the end of the talk too, but it's a good place to put it in because these are mainly around the non-pharmacological interventions. So geriatrician's always good if you've got access to one, but that's not always the case. But there are some really good 24-hour support services for both GPs and also the family and the carers, particularly Dementia Support Australia.
Yeah,
is
that's
one
right.
that I often tell people about and give the phone number to.
And there's the GP advice service, which is a part of that too, Pete. But you send them an email, and so it's not an immediate response, but they can be very helpful as well.
And what's the Dementia Behavioural Management Advisory Service?
Yeah, I mean, that's all part of it. And the severe behavioural response team, that's when you need more immediate sort of help.
Yep.
And there's a number for that as well.
Yep.
And the older person's mental health team, I'm not sure if that's nationwide, but certainly here in New South Wales, it's a referral, sort of a public-based referral. And it can be helpful. Oh, you've got one too?
We've got one up here, yeah.
Yeah, I think they're quite good for people who have a history also of mental health problems, and sometimes it's quite difficult to know how to treat that in the context of the dementia as well.
Yeah. So Anna's now permanently, he's been settled there for a while, permanently for 6 months, and the behaviour that's been discussed is increasing, particularly calling out and now also getting a bit anxious about things. She repeatedly tells the staff that car accidents on the news are about her son, and she's pretty upset that he has died, which he has not, and may even lead to her calling her daughter at 2 o'clock in the morning. Staff are sort of wondering whether maybe she needs some medication, maybe to help her sleep better at night or to calm her down. And not quite sure what you think about that language, Beck, but let's have a talk about how we assess Anna from here. What do you think about that? The language of calm her down.
Well, again, it's I think you just need to be fairly specific in what you're trying to achieve, really.
Yeah. I mean, it's an interesting one, isn't it? Because it could definitely be misinterpreted, especially today. It's probably, I think what they're really trying to say is to make her feel more comfortable, to make her feel
to relieve
settled,
her distress,
to be able to sleep better. So I think it's better to use words like that.
I agree.
So here's our assessment. Yep. So we've done the first. So we've done the biological delirium. We've talked about environmental triggers. So we're now going to have a talk about depression and possible other more serious mental health reasons. So could there be a psychiatric trigger? Well, yes, there could be, couldn't there?
Absolutely. And I think certainly what she's describing sound very much like delusions. And having said that, we do need to assess for features of depression. And these here listed are all suggestions that possibly there is an underlying depression. So people seem to be more withdrawn. They don't want to go out of their room as often. They're not eating as much. So weight loss is often a red flag that there's some psychiatric concerns. Some people will actively voice suicidal ideation or thoughts of not being here or just wanting to go. As I've mentioned before, anxiety can often be a feature of dementia as well. And then those more features of hallucinations and delusions, which it does sound like she's experiencing now too.
So just to explain that too, you can have symptoms of anxiety, depression, and psychosis as part of the dementia, but it could also be or by itself a reemergence of an underlying mental health illness that the patient had in the past. So it can be a bit tricky to maybe work out which is which, but the treatment's pretty much the same. So in that sense,
it is. I think from my understanding, I think people who have a history of depression or anxiety are more likely to respond to the medication than those for whom the depression or anxiety is a part of the dementia itself. Yeah. And they say about people living with dementia, when they're age matched, have about twice the rate of depression than their counterparts.
Yeah, so this talk's going to now sort of delve into more sort of pharmacological treatments. And we're going to start with things you could possibly use for depression and anxiety. And really the medications are sort of ones you're probably quite used to using already. I usually use one of the prams, like citalopram or escitalopram, because well, that's what therapeutic guideline says. And I think the studies that have looked at this for some reason use those ones and they seem to work. So I don't know whether they had head-to-head trials against sertraline, but I don't know if you know that, Beck.
Well, they did like that. To be honest, I think reading the trials, I don't know that there's a lot of evidence for any of them for use in dementia. But as I said, for those people who have an underlying depression or anxiety, certainly they're recommended, and they're still recommended as a trial anyway. But you're right, the citalopram, there is definitely evidence that this is the most beneficial, particularly in people who are experiencing an agitation related to their depression.
And I always start people on a half a dose because, you know, start low and go slow in the elderly. And also because they've got reduced cognitive capacity and a greater risk of side effects. And yeah, my experience, they can be really useful.
It's so person-centered.
What's that? Sorry?
Very person-centered, isn't it?
Very person-centered, yeah.
So Pete, how long do you keep someone on before you either increase the dose or take them off it altogether?
Yeah, that's a really good question. It's probably just the same as I do with anyone with depression, really. I just have to make an assessment on the time. I mean, I think if you've started a drug for depression, anxiety, and it's worked, you know, I'm not really reviewing it probably unless side effects emerge for 6 to 12 months. And if a drug's worked and they're happy and they're 85 and, you know, their dementia is progressing, I don't really get too stressed about stopping it because I don't want to sort of rock the boat, especially if they're not getting any side effects.
Yeah. And what about, like, I often struggle to know at what point you decide it's not working and then you take them off. I mean, I don't know.
Yeah, well, I mean, again, with SSRIs, I use my clinical judgment. You know, I give them a few weeks at least, as long as they're not getting side effects.
Yeah.
I don't. That's what I do in clinical practice. I don't know if you've got any other.
No, that's what I do too. And I don't, and I've spoken to geriatricians before, and essentially I think that's right. So after about 4 weeks, you increase the dose. After about another 4 weeks, you have another look. And, you know, after a couple of months, if you don't feel that at a reasonable dose it's doing anything, I think it's quite appropriate to deprescribe.
Yeah, definitely stop them. But
the other thing is mirtazapine has a few additional benefits in terms of appetite and in terms of sleep. And so depending, again, on what the person's symptoms are, mirtazapine might be something to consider as well.
Yeah, and just remember, the lower the dose, the more sedating it is. And it's also got a powerful antihistamine component to it, mirtazapine, and I've actually been using it in someone who has quite resistant allergic rhinitis, and it's helped a lot. So there you go. There's a little tip outside of dementia.
A little off ladle.
Yeah, that's right. Yeah. So now the other one is the cholinesterase inhibitors. So they may already be on one of this, but if they're not, and it hasn't been used yet, this is suggesting you can start them even in the later stages, not so much for the potential cognitive benefits, but to help reduce depression and anxiety. That's correct, Beck?
Yeah, I think that's appropriate because we do know that the cholinesterase inhibitors may also help with changed behaviours and agitation. But yeah, generally to be able to prescribe them on the PBS, you need to have a person who has Alzheimer's dementia, and you need to have an MMSE of more than 10. Having said that, certainly there is evidence that they're beneficial in other dementia forms like Lewy body, but that would be something to discuss with the geriatrician.
Which you need to do as well. Unfortunately, that's an old PBS authority that hasn't yet changed. So you're probably going to end up talking, well, you have to talk to the geriatrician or the specialist, psychogeriatrician, whoever the specialist involved is in to start these medicines too.
I guess you want them on the PBS, yeah. If
you want them on the PBS, yeah. I guess the other thing too to remember is like if they've been on these medicines and then they're stopped for some reason, you can actually have a reversal of their benefit, and that may cause an agitation or a change in cognition too. So that's something to think about as well.
Yeah, and often I've found the geriatricians would be quite reluctant to take someone off it. Yes. Until, you know, really sort of much later stages for that very reason. You're not sure that it's doing much, but then when they come off it, you think, oh, actually that was really helping.
Yes, that's right. Yep. So then there's the benzos, which are sort of more last line and require sort of more thought and careful thinking about if you're going to use them. So you really need to get informed consent from the family that's correct, Beck?
I think for all of those medications, you do need to discuss and have informed consent either from the person living with the dementia if you believe that they have the capacity, or a substitute decision maker. Because all of them do have potential side effects as well.
Yeah, they do. I mean, we didn't go over the various side effects in the cholinesterase inhibitors, but the list is long, like an SSRI. So you do need to consider, especially the absolute contraindications like heart block in the cholinesterase inhibitors. So this slide is really just to remember that when you're starting those medications, to have a talk to the family and the person living with dementia if they still have capacity to give you consent. And just always weigh up the risks versus the potential benefits, and go for something that's least harmful for the shortest period of time, which is general good principles of any sort of medication use. It doesn't really change, does it?
That's right.
At any stage. Yep. So then there's the antipsychotics. So a little bit more controversial again.
Again, because of their side effects, isn't it?
Yeah. So tell us about these two, and when you sort of how you think about these and when you might use them.
So I find that so as per the therapeutic guidelines, both risperidone and olanzapine have been are potentially indicated for these changed behaviours, and this is in basically when everything else has been trialled, and when it's perceived that the person is significantly distressed and or a danger to themselves or to other people. And we do need to be really careful in prescribing antipsychotics, partly because for many people they're not particularly beneficial, and partly because they do come with a significant side effect profile, including sedation, increased risk of extrapyramidal side effects, and increased risk of stroke. It's pretty important that we understand their type of dementia as well, because people who have a Lewy body dementia or a dementia that's associated with Parkinson's disease are going to be a lot more sensitive to antipsychotics. And so that's, again, an area that really does need discussion with the geriatrician, because if you give antipsychotics to somebody who has one of those conditions, the risk of extrapyramidal side effects is quite high and potentially can be fatal. So
and that's right, and that needs to be weighed up. The same with the risk of stroke, with the person's dignity and their level of comfort, and the family and the person's decision about use of these drugs. I mean, normally by the time you're using risperidone or olanzapine, it's more a discussion with the family. But sometimes, like, we use lots of drugs that have got lots of risks, including, not limited to antipsychotics, and sometimes it is appropriate. So I guess what we're saying here is certainly they're not first line, but B, if you're going to use them, make sure you're talking to the family about it, and C, just follow the guidelines, because they've really revamped them, haven't they, in the last 12 months?
Yeah, that's
in an effort
exactly
to
right.
make them a lot safer. And if you do that, like the sort of things we've got here, which is all pretty much listed in the PPS guidelines anyway, then you're not going to run into, hopefully you won't run into too much trouble.
Yeah, I think this is important. So in terms of what's PBS listed, risperidone is the only antipsychotic that's PBS listed for this, for changed behaviours in Alzheimer's dementia. And it is that it needs to, so you need to firstly do an initial authority for the 12 weeks.
Yeah.
And then you have to be able to show that you've attempted to wean, and that it has or it hasn't been unsuccessful. If it's been unsuccessful, then you need to discuss formally with a psychiatrist or a geriatrician the continuing use of risperidone.
And you talked about some of the side effects there around sedation and extrapyramidal side effects, increased risk in hospitalisation and death doesn't sound very good.
No, and it is a horrible conundrum sometimes, isn't it? Like, I have a lovely lady, but a decision's just recently been made to trial some risperidone because she can become quite distressed, very agitated, and she walks constantly. And it was felt that trial of risperidone would be appropriate, but then she had a fall, and then you wonder, it's a
was the fall from the risperidone?
Well, we don't know,
Yeah, I think, and certainly I think get some help if you're not sure, what to do or not confident. Did her agitation improve?
Sort of.
Yeah.
And I think that's where behaviour charts can be really helpful as well. So to do a behaviour chart before, and then to trial some medication and to do a behaviour chart then, because otherwise it's all very anecdotal, and it depends which staff member you talk to and how they present to you on the day. So I think behaviour charts are a bit more objective. And I think in cases like that, I've been talking to the geriatrician about it, because it's a real balancing act. In her case.
So there are some groups of medicines where if you're using it for agitation alone, there isn't evidence. Particularly, probably on the screen there to note would be opioids, but maybe also melatonin's thrown around a lot, isn't it, Beck?
Yeah, so I mean, what we're saying is, like, there might be the agitation if it's caused from pain. Certainly opioids may be an appropriate thing, and we do other talks on end-of-life care and palliative care and dementia, etc. There's definitely a role sometimes for opioids, but just to use purely as an agitation measure is not appropriate. And similarly, there's no evidence for melatonin purely for agitation. To be honest, I don't think there's very much evidence for any specific medication for use in sleep in dementia, but certainly melatonin is frequently used because it has a relatively safe side effect profile, and because we know the circadian rhythm in dementia gets disrupted as well. There's some theoretical benefit to it, and again, if it works, then melatonin is a relatively safe thing for sleep.
Yeah, I wonder whether some of those new melatonin-based antidepressants will get studied.
Yeah, that's right. I don't think they've done the studies.
No. So back to Anna. So when the staff call you about her agitation and calling out, how will you approach using this framework for assessment? So we've got a bit of a wordy slide here, but this is kind of just the summary, isn't it?
Yeah, I think this tries to explain all the different things that we might consider. I mean, in Anna's case, the main issues are the agitation, vocal disruption, and I think also those the delusions that she was having that were quite distressing for her about her son. So, you know, there are things that we can do, taking a person-centered approach. I mean, we know from previous times that Anna actually really enjoys her garden. So one thing that might be really good for Anna is to have somebody take her outside and, you know, have a little plot of land that she can work the garden with, or keep orchids in her room. That sort of thing, again, would be one of those non-pharmacological interventions that just might help. Music therapy, aromatherapy, pet, animal-based therapy, again, all easy to do, and it's a matter of finding what fits her really. There is the evidence for the atypical antipsychotics. Having said that, they don't work for everyone. They're often short-term benefit, and so it certainly wouldn't be unreasonable for a trial, but continually looking to wean as well. And in terms of the vocally disruptive behaviour, trying to exclude all those things we talked about, pain, delirium, features of infection, etc., music therapy, and physical activity as well. And certainly in her case, it may be reasonable to trial an antidepressant and SSRI, because certainly there were some features, I think, of a depression.
Yeah. And if you can't remember that, there are some really useful resources, and Health Pathways, which was mentioned at the start of this talk, I'm guessing has got a lot of these on their pathway, which is definitely would be worth looking at. There's some other on the screen here. We talked about Dementia Support Australia. Dementia Australia is probably something that all the people on this webinar would have heard about. Forward with Dementia is maybe something you haven't. So Forward with Dementia is also sort of an advocacy and educational type website like Dementia Australia. It's a little bit more simple to use. There's probably not quite as much information on there as the DA website. And some of the stuff's a little bit easier to read. So I think if you haven't had a look at that, it's definitely worth having a browse around. What do you think, Beck?
Yeah, absolutely. And I do feel like tonight we've spoken largely about residents in nursing homes, but in fact, all of these things hold true for people living in the community, and most people living with dementia are in the community. DSA, so Dementia Support Australia, will come to the house, and so carers can certainly call Dementia Support Australia and expect to get some good help. And that Nightingale program is, I think it's being trialled in Adelaide at the moment, but that's sort of more for palliative end-of-life care in dementia, in which sometimes, changed behaviours can really be part of that as well. And so I think ultimately they're going to try and expand that across the nation.
Yep. And then we've got a really cool podcast that we recommend to you called Dementia in Practice. And there is an episode on living in residential aged care. So we recommend you go and check that out. Listen to it in your car on the way to work, maybe while you're walking the dog. That's where I listen to my podcast. I don't know about you, Beck, but that's my favourite place. This is our last slide, which is really our take-home messages, which is that the management of changed behaviour is more than just the use of medication. Hopefully we've got that across loud and clear. And there are many resources to assist you, from your health pathways to the websites we talked about. Particularly, just remember Dementia Support Australia, which is really set up for this kind of stuff, and both for your patients and also for yourself as GPs. All right. Well, that brings our talk to an end, Beck. We're right on time. Have you checked the
I've been checking, but yes, actually questions are really good. If anyone has any questions, then it makes it a bit more interesting.
feel free to jump on and have a look. Send us a question, I should say. Bring up my there's nothing coming up at the moment. So Gil, did you have something at the end there you wanted to do?
Hi, Peter. Yeah, I can finish off with a couple of slides if you like, if you want to unshare, and I can share my.
I've unshared. It's all
Great.
yours.
Thank you. Sorry. Just takes a minute. Can you see my screen now?
Yeah.
Right. So just to finish up, thank you very much. That was really fascinating for someone who's worked in the past in residential aged care as a physio. I'm sure everyone else has found it that there's a lot of new and interesting information coming out. So that was great. Thank you. I've just put the login details on here for both Health Pathways sites for anyone who's not a current user, but you're welcome to get in touch with your PHN if you want to get access to use Health Pathways. And we mentioned before, there's lots of different pathways on there that are related to dementia, like you said, Peter. The other part of the Dementia Pathways program that we have been working on, both PHNs have mapped the local services available and developed these resources which are designed, one's patient facing and one is carer facing. So for people who are living with dementia, these resources are for this ACT, and you're welcome to get in touch. We've got them on our website, but you can get printed versions if you're doing face-to-face work with patients. And then the New South Wales version is there as well. So get in touch with your PHN if you would like those. I mentioned Health Pathways previously, and just to let you know, on every page of Health Pathways, there's a big button at the bottom right-hand corner that says send feedback. Our Health Pathways program relies on a sort of circular communication with clinicians out in the field, as well as the writers that we have. So if you're on Health Pathways, feel free to get in touch with us about any changes you think need to be made, or changes to your services, etc. It's good to get that feedback from you as well. And just finally, thanks very much to our presenters, Peter and Rebecca. If we can please complete your evaluation survey, everyone, when you get that comes out, it will come by email, as that gets your CPD points as well for GPs who are online tonight. Recordings are available. We put all of our webinars on CHN YouTube site, and coordinate, I know, use Vimeo. So you're welcome to look back. And as you said, Peter, there's the first 3 sessions are available on there as well. So feel free to go back and have a look on there as well. And I'll stop at that. Thank you very much for your presentation, and thanks very much everyone for attending tonight.
Thank you.
Thanks a lot. Bye.